Yes, of course, but not
So,
all forms of radiation are harmful. Radiation cannot be smelled, cannot be touched, cannot be heard. You cannot see the radiation by your naked eyes, except for visible range of radiation. But for radio waves, microwaves, infrared, ultraviolet, X-ray, gamma ray, you cannot detect any of those types of radiation by your naked eyes, but you cannot touch it, you cannot smell it. So we are dealing with something which is unseen to everyone. So your room now contain different types of radiation around you. Everyone eating rice, drinking milk, eating beef, fish. So there are certain amount of radioactive material inside our food, like potassium 40, carbon 14, rubidium 87, tritium. The highest concentration activity comes from potassium 40. This potassium 40 has 0.01% of potassium is radioactive in our normal potassium intake. So this potassium 40, if your body weight here, for example, is 70 kilograms, that's mean your body contain around zero point 0.1 microcurie of potassium 40. That's mean 24,000 photons emitted per minute. Its time half-life of potassium 40 is 1.3 billion years. Potassium 40 can emit 89% beta particles and 11% gamma ray. That's mean your body contain a certain amount of radioactive material coming from your food or your daily intake of food. As you can see here in this table, from rice, you can get around 150 gram per day. So it contains 0.126 from radium and 0.267 from thorium, and the highest concentration activity come from potassium 40. So as you can see here on the right side, you will find the high concentration activity come from potassium 40 for different food types like wheat, pulses, vegetables, milk. So you have to be careful about that. But your body now contains a certain amount of radioactive material. So radiation everywhere. Also, if you are going to measure the background radiation, if you are going to measure the background radiation, you will find the background radiation differ from one country to another. If you are living in New Delhi in India, you will find the background radiation 0.079 microsievert per hour. In Bangalore, India, 0.094 microsievert per hour. But if you are living in Iran, where there are a lot of mountains there, so you will find the background radiation is 1.14 microsievert per hour. So based on the country nature, if there are a lot of mountains, that means there are a lot of contents of thorium and uranium radioactive material, so you will find high background radiation. In United Arab Emirates, you will find the background radiation is around 0.033 microsievert per hour. So based on the country nature, you'll find the background radiation reading differ from one country to another. Also, if you are going to travel from one country to another, so if you are monitoring the level or the height level at which your airplane there, you'll find yourself around 15 kilometers from sea level. So at that time, at that level, you will find yourself to get exposed to 10 microsievert per hour. So if your flight takes around 3 or 4 hours, you will get exposed to 30 to 40 microsievert as the total dose received by your flight. So, do we need radiation protection? As we are living with radon gas come from construction building, we are living with potassium 40. If you are going to travel from one country to another, you will get exposed to radiation. So, radiation everywhere. Radiation coming out from your cell phone, from laptop, from ceiling, from ground, from walls, from food, everywhere. So, do we need radiation protection? Of course, we need radiation protection. And you can see here on the left side, this patient suffered from hair loss and scaredness, which happened because of high dose exposure due to CT perfusion technique, computed tomography. Under high dose of exposure, reached to 3 to 4 gray as an absorbed dose to the skin redness and hair loss happened to this patient. This has happened to some patient because of high radiation dose or high radiation exposure. As you can see here, ICRB 85 record some injuries happen for some patients after radiation exposure under fluoroscopic procedure. After weeks and months from the procedure, they get exposed, they get tissue damage, as you can see here in those image. So ICRB recommend warn patient of risk if the maximum skin dose exceeds 3 gray. Identify patients who have repeated interventions where the dose exceeds 1 gray and warn them of risk. Not only patient, but also intervention radiologists, our workers, get suffer from cataract because of the scattered radiation coming from fluoroscopic procedures. As you can see here, ICRB 85, 2001, here in this report, record a lot of intervention radiologists get cataract because of the scattered radiation coming out from the patient. So we need radiation protection. What can radiation do? Radiation can cause death, cancer, skin burn, cataract, infertility, genetic effects. So let's go through the main principle of radiation protection to understand more about the biological effects of radiation and radiation types, radiation units, and measurements. Under any medical or under any facility, you'll find three main categories should be protected from the radiation hazard. The first one is the medical exposure, second one, occupational exposure, third one, public exposure. For the first one, if you are patient going to do a certain procedure, so now you are under the medical exposure. If you are care or comforter to this patient, so now you are under medical exposure. For any volunteers subject to exposure as a part of program of biomedical research, so now under medical exposure. The second point or the second category is occupational exposure. For those involved in the performance of radiological procedures, for us as a workers, for technologists, for physicists, for people involved in the performance or in the procedure of scan itself or radiological procedures. Public exposure for members of the public, such as people in waiting rooms or people in the adjacent rooms or your colleagues working in another department. So we have to work on protection, the three main categories in any facility. Medical exposure, now we are talking about the patient. Occupational exposure, we are talking about our workers. Public exposure, you are talking about your colleagues in other departments or patient or public waiting in the waiting room. ICRB here, three fundamental principles of radiological protection are justification, optimization, application of the dose limits. Justification is the main rule of our radiologist. Our radiologist has to conduct, has to do justification for any procedure to make balance between the benefit and risks. So now I have to get more benefit than risk for any procedure. So the main rule of justification this is the main rule of our radiologist. So our radiologist should make a phone call or should discuss this procedure with the referrer. If the referrer refer any patient for CT abdomen or X-ray, so if there is another procedure can be done for this patient and can reduce the patient dose, so we have to do it. So justification, we have to weigh the benefits and risk and to see and to get higher benefits than risk. So now we have to apply the justification procedures for medical exposure. And we have to apply optimization procedure as well. So we have here, as you can see, justification, optimization, limitation of doses or dose limitations. The first concept we are talking about justification. You have to justify the case itself. This is the main rule of our radiologist. Optimization means you have to reduce the acquisition parameter to get an optimal diagnostic image quality with less radiation dose. And this is the main rule of our technologist. And the main rule of our medical physicists to get involved in this one, to adjust or to design a certain protocols which deliver less dose to the patient with an optimal diagnostic image quality. Those limits, we cannot apply those limits for any patient for medical exposure. You cannot say that's enough, this patient already had too much exposure this month. If the patient case or if the patient required to be scanned one more time to save his life or to be diagnosed, you should do that. Don't say there is a certain dose limit, we cannot exceed it. There is no dose limit for any patient. Only the dose limits can be applied for public and occupational exposure. But for patient, we don't have any dose limits. Types of radiation. Types of radiation according to the energy. As you can see here, we have two different types of radiation. First one is ionizing radiation. So we are talking about X-ray, gamma ray, as a type of electromagnetic radiations or electromagnetic waves. And we have another type which is called non-ionizing radiation, like MRI, radio waves, TV, mobile tower. So you can go inside the MRI room. You can use your cell phone for a long time. You can watch TV for a long time because this is non-ionizing radiation. Non-ionizing radiation means that it has not enough energy to knock out electron from the atom. So it means that it will not produce any ions inside the patient body or inside your body. That's why it's safe to deal with non-ionizing radiation like MRI machines, radio waves, TV waves, or mobile tower. Because this type of radiation has low energy, low frequency, and high wavelengths, cannot cause any ionization. But for ionizing radiation, we are talking about X-ray, gamma ray. So it has high energy, high frequency, but low wavelength, and it can cause ionization. Here, X-ray or gamma ray has enough energy to knock out electron from the atom. It means it can cause ionizations. As you can see here, the electromagnetic spectrum, you will find non-ionizing radiation and ionizing radiation. Non-ionizing radiation, there are many types under non-ionizing radiation, like microwaves, like TV, like cell tower. But for ionizing radiation, we have gamma ray, X-ray. Just a question come to my mind. What about the ultrasound? Ultrasound is a type of ionizing or non-ionizing. Actually, the ultrasound is not a type of electromagnetic waves. It's a mechanical wave. So there are specific characteristics for electromagnetic radiation which vary from ultrasound waves. So you cannot consider the ultrasound wave as a type of electromagnetic waves, as electromagnetic waves doesn't require any medium to pass through it or to travel from one point to another, while the ultrasound waves require certain medium to travel from one point to another. That's why when we are talking about the ultrasound wave, we are talking about different type of waves or different types of radiation, which is mechanical waves or longitudinal waves, while ionizing and non-ionizing is transversal waves of the radiation. So here, as you can see, if you have enough energy, so you can knock out electron from the atom, so these electrons will be knocked out from the atom. So the atom itself become positive ion, while the electron become negative ion. That's why ions produced inside the patient or inside our bodies under radiation exposure. And this is the main difference between ionizing and non-ionizing. These ions, which are produced inside your body, will attack your DNA. So now, under ionizing radiation exposure, many ions will be produced inside your body. These ions will attack your DNA and it might cause damage, might cause DNA mutation, might cause genetic disease, might cause cell apoptosis, might cause cancer. There are different probabilities based on the radiation dose itself. Why non-ionizing radiation cannot cause any ionization or any ions production inside your body or inside the worker? So as you can see here, every day your DNA, 10,000 to 1 million locations have been damaged every day without any radiation exposure. And the cell itself produce repair enzyme trying to fix all this damage. But if this damage failed to be repaired, at that time, this damage might cause cell apoptosis, might cause cancer, might cause genetic disease. Under radiation exposure, you are increasing the probability of damage. So you are reducing the probability of fixing this damage. So at that time, the cancer or genetic disease can be initiated easily under radiation exposure. If we are going to classify the radiation types based on the source, we have man-made source, we have natural source. Man-made source, that means you can turn it on, turn it off. That means we are producing X-ray machines based on artificial sources or based on or artificially. That's like fluoroscopy, like dental X-ray, like linear accelerator, computed tomography, mammography, cone beam CT, bone mineral density or densitometer. All these machines under man-made source. So you can turn it on, you can turn it off, you can control it easily. Why natural source of radiation? Now we are talking about RAM, radioactive materials. So radioactive material, you cannot control the radioactivity of the material. You cannot control the emission or the radioactive material. You cannot say or you cannot make it on, make it off. You cannot do that. Why? Because the radioactive material itself emits radiation until it's totally decayed. So you cannot turn it on, turn it off. That's why natural source of radiation, we are talking about radioactive sources, which are emitting gamma rays, alpha particles, and beta particles. So we can use the radioactive source for diagnosis and for treatment as well. Let's start with man-made source. The man-made source of radiation, we are talking about different types of X-ray machines in our medical facility, X-ray, fluoroscopic machines. We are talking about mammography. We are different types with different energy. Why? Because based on the purpose or the application of the machine itself. As you can see here, you will find the X-ray tube, which is the main part in our X-ray modalities. This X-ray tube will produce our X-ray based on the interaction happening between the electron coming out from the cathode and the target anode. You are controlling the energy and number of photons produced from the X-ray tube by adjusting the kilovolt or the potential difference between the cathode and anode. When you are going to increase the potential difference, that means you are giving more energy to the electrons to move towards the target anode. So the X-ray photons which are produced from the X-ray tube will have high energy, and number of photons which are produced from the X-ray tubes will be higher. So by increasing the KV, you are going to increase the energy of X-ray, you are going to increase the number of photons produced from the X-ray tube. The interaction happening between the electrons and the target anode, there are two different types of interaction. One of them is called Bragg radiation, where the interaction happening here between the electrons and the column field around the nucleus. So here the electrons will be attracted or will deflect its pathway because of the positive energy of the nucleus. So at that time, the breaking radiation or breaking X-ray will be produced. While here, the interaction happening between the electrons and the K-shell electrons. So at that time, another electron will come from higher ground state or higher energy state to fill the gap left here. So the difference in energy will produce the characteristic X-ray. So we have two different types of radiation: characteristic X-ray and Bragg radiation. So we are using Bremsstrahlung X-ray in our imaging procedures. So now this is our spectrum, which representing the Bremsstrahlung X-ray and the characteristic X-ray. I'm not going to throw more details about that. I'm just giving you idea about the KV as the important parameters which increase the number of photons and increase the energy of X-ray. Here in radiation oncology department, we are going to use linear accelerator, which used for treatment or cancer treatment. So at that time, we are going to use high energy X-ray reach to million electron volts. We are going to use 10 or 15 million electron volt as a maximum dose energy or the maximum X-ray energy, which is suitable for cancer treatment. While in our radiology department, we are going to use low level of energy in kilovolt range. So here in radiology, maximum KV can be given to the patient is 100, 120 KV. And exposure time is very short, which is around in millisecond. So as you can see here, we are going to use the X-ray for imaging the patient under radiography in very short time, millisecond, fraction of seconds, and the KV is in KV range. Now we are talking about the fluoroscopic machines, which is the highest radiation which has the highest radiation hazard among all types of diagnostic modalities. Why? Because here in fluoroscopic procedure, we are going to inject the patient with contrast media. So we are going to scan the patient in dynamic mode. So at that time, you are acquire image per second or not a certain number of images. So this procedure lasts for 1 hour or more than 1 hour. So at that time, the patient get exposed to higher dose of radiation, and all operators and doctors and nurse, all team around the patient will be in close contact with the patient. So in fluoroscopic procedure, we have many scatter radiation coming out from the patient because of long exposure time, and they are very close to the patient during the procedure itself. So there is a higher radiation hazard to the patient and to the worker in fluoroscopic procedure. That's why fluoroscopic procedure considers the highest radiation risk among the radiation or diagnostic facilities. There are many applications for fluoroscopic procedures and also can be used for orthopedic surgeons. Also, radiology department, we have computed tomography, which can be used for 3D or angiography or cross-sectional images. So at that time, we are giving the patient, or we are going to give the patient high dose or high KV range reach to 120, 140 kilovolt. And if you are going to scan the patient for multiple procedures like arterial phase, portal phase, venous phase, and delayed phase, so the total dose received by the patient is around 100 milligray. So you have to be careful about these dose, and you have to monitor these dose for the patient, especially in computed tomography. That's why computed tomography considers the second in the risk of radiation among the diagnostic facilities. Actually, mammography, the maximum KV can be used is 35 kilovolt. We are using this machine to detect the breast cancer because here we are going to use low kilovolt to maximize the difference between the different tissues inside the patient breast. For dental department, actually, we have intraoral and we have panoramic X-ray. In intraoral, you are in direct contact with the patient. So at that time, you have to be careful about the number of patients or number of procedures you are going to have every day. But in panoramic X-ray, you are scanning the patient and you are in the control room. So you are away enough from any radiation hazard, like computed tomography. But for dental department, be careful about the radiation exposure as you are in close contact with the patient. And if you have many patients every day, that means you get more scattered radiation received by your body. For natural source of radiation, we have a certain material. Each material composed of atom, the atom composed of nucleus. So we have here number of protons and number of neutrons. Now the main question I have for everyone: why the atom become radioactive? Because there are imbalance between the number of protons and number of neutrons. If there are excess number of protons, that means the atom itself become radioactive because the high number of protons increase the repulsion force, so the atom become radioactive because it tends to be more stable, so the atom will convert one proton to neutron. That happen in alpha decay and beta plus decay for positron. In alpha decay, we have a higher number of protons exceed 83. That's why it happened with heavy atoms. Alpha particles produced from the atom, that means there is conversion from the unstable state to stable state. Alpha particle has penetration power, which is the lowest among the three types of particles, and it can be blocked by a piece of paper or a few centimeters of air. Its ionization power is the highest among the three types of particles. That's why alpha particles can be used only for treatment, not for diagnosis. We are going to use actinium-225 225, which producing alpha particles, which can be injected to the patient and can be targeted to the tumor. Alpha particle has a high ionization power, so it can deposit all its energy in a very short distance, so it can destroy the tumor. Beta plus decay, here we have an excess number of protons, so the atom tends to be more stable, so the atom will convert one proton to neutron, so at that time positron will be emitted. So this positron will collide with another electron in the medium in 2 millimeters to produce two gamma photon 511 kilo electron volt based on Einstein equation. So it can be used for positron emission tomography, PET-CT. We are going to use F18 or fluorodeoxyglucose, which can be used for tumor imaging, which is producing positron, which can collide with or can combine with another electron in the medium or around, so to 180 degree or in opposite direction. Beta minus decay. So now we have high number of protons. So the atom tends to be more stable. The atom will convert one neutron to one proton and produce electron. This electron has a short distance. It has middle ionization power and it has a middle penetration power. So it can be used also for treatment. So a golden example for beta minus decay is iodine 131. Iodine 131 can be used for thyroid cancer treatment. So we are going to give the patient or to administer iodine 131 for thyroid ablation and for thyroid cancer treatment. Beta minus decay, it can be stopped by low density material like plastic sheets. For gamma radiation, it can go after alpha and beta plus beta minus decay. It doesn't have a charge. That means it has the highest penetration power among the three types of particles, and it can be blocked by several centimeters of lead. We have to use high dense material, high lead material to stop gamma radiation. Its ionization power is the lowest among the three types of particles. So any source emitting gamma radiation can be used for diagnosis, not for treatment. So gamma radiation can penetrate the patient body to be detectable by gamma camera or SPECT machine. So that's why we are going to use technetium 99M, which produce 140 kilo electron volt gamma radiation, which can be used for imaging, not for treatment. So now briefly, alpha particle, 2 proton plus 2 neutrons, helium nuclei, charged particle, has high ionization density and has low penetration power. Beta particles might be electrons or positrons. Charged particles has middle ionization power and can be used for treatment if it's beta minus, but beta plus, it combines with electrons in 2 millimeter distance to produce 2 gamma photon 511 kilo electron volt in opposite direction. X-ray, gamma ray, as you can see here, low ionization density, high penetration powers. If I am going to stop the gamma radiation, I have to use high dense material like lead with a certain thickness, which is equivalent or which is enough to stop the gamma radiation energy. While for alpha particle, you can stop it using thin sheet of paper. Beta particles, you can stop it only using low density material. Be careful or put in your mind. Don't try to use high lead thickness with beta particle. Why? Why cannot use the lead with beta particle sources or beta emitters? In this time, if you are going to use lead material directly to stop the beta particles will produce Bremsstrahlung X-ray because of the interaction between the beta particles and the atom of the lead. So it will produce Bremsstrahlung X-ray. So don't try to use it for this purpose, but try to use low density material like plexiglass or aluminum. As you can see here, there is a good example for detection of different radioactive sources. We have here alpha radiation, and we have here pancake servimeter. This pancake servimeter can be used to detect, which is highly sensitive to detect the radiation. This is our probe, or this is our detector. If you are going to move the alpha source close to this probe, you will find here this arrow going up. That means you are getting more radiation can be detected from this alpha source. But here, if you are going to stop the alpha particles, only you can use a thin sheet of paper. So at that time, all alpha particles will be stopped here. So it will not penetrate the paper to reach our detector. So you will find here the arrows goes down because of that. And there is another example here. You can use the beta particles or radioactive source which emit beta particles. So at longer distance, the beta particle can travel more distance than beta particles. That's why the beta particle here is at higher distance than alpha particles. So here, if you are going to detect the beta particles, so you will get here a certain reading. If you are going to use the thin sheet of paper to stop beta particles, you cannot stop it. You cannot stop it because beta particles can penetrate thin sheet of paper. So you have to use low density material like plexiglass or plastic or aluminum sheets. So that's why you will find here or the arrow goes down. Third example we have, if you are going to use the gamma radiation source, as you can see here, and if you are moving the source close to the probe, as you can see here, so now you will get a certain reading. But if you are trying to stop the gamma radiation using the thin sheet of paper, you cannot do anything. Using the low density material, you cannot do anything. But the only material can stop the gamma radiation, a thick or a proper thickness of lead. So the reading is still the same value. You cannot stop anything here. So you have to use a proper thickness of lead to stop the radiation coming out from the radioactive source. So the RD start going down. As you can see the difference without the lead shield and after. So there are different reading between with and without the lead shield. So distance can be traveled in air. For alpha particles, 1 to 10 centimeters, and for beta particles can travel several meters based on the energy of the beta particles, while for X-ray gamma ray can travel several tens of meters depending on the amount of energy. Upon collision with the patient body, as you can see, alpha particle can travel tens of micrometers, beta particle can travel several millimeters, while X-ray gamma ray can travel several centimeters and can also penetrate the patient body to the other side based on the energy. So here, if you have different sources of alpha particle, beta particle, gamma radiation inside the patient body, so alpha particle cannot penetrate the patient body. It will deposit all its energy inside the patient body. That's why it can be used for treatment. Beta particle, it will travel more distance than the alpha particle. But the highly effective one in therapy is the alpha particle. But unfortunately, we don't have many alpha emitters used nowadays for radionuclide therapy. Beta particles, the only one which is very common in radionuclide therapy, like iodine-131, like lutetium-177, and Y90 for liver radioembolization. While here in gamma radiation can travel more distance and it can travel the patient, it can travel out the patient body and it can be detected by our gamma cameras. Here, upon collision with the patient body as the surface of the patient body, alpha particle cannot penetrate the patient body. It will be stopped here. While beta particle can travel more distance, gamma radiation can travel longer distance and can penetrate the patient body as well, based on the energy of gamma radiation. So we have in nuclear medicine department, we have gamma camera or SPECT, and we have PET-CT as well. So for the gamma camera, we are going to inject the patient with radioactive material. So you have to be cautious about that. If you have a patient in nuclear medicine, so you have a different sources of radioactive material. We have radioactive sources inside our hot lab, in waste room, injection room, or dosing room, and we have our patient who is injected with radioactive material, and they become a new source of radiation. And these patients going through the department, going from dosing room to scanning room, from one room to another. So you have to be careful about that, and you have to know how to protect yourself and your staff from the radiation exposure, like giving all the patient instruction before dose administration. Like if you are going through the layout or the design of nuclear medicine department, you should have a gate for, or a door for a patient entry, and you should have another door for patient exit. That's very important if you are going to design the nuclear medicine department. Don't let the patient go back to the entry door and start talking with receptionist, and he's radioactive now. Okay, so if he go through the hospital, so now he will use the elevators, and he might stop for a while to talk with some people, and talk with pregnant people and pregnant staff and exposed children. So you have to be careful about all this. Okay, I'm not going through these more details about the nuclear medicine procedure. How can we protect ourselves? We have to use ALARA principle. ALARA principle means that as low as reasonable achievable, you have to differentiate between necessary radiation exposure and unnecessary radiation exposure. For example, if you are working with nuclear medicine department, and you are every day morning, you are going to the hot lab, start preparing your radiation dose. So at that time, you get exposed to a certain amount of radiation. Is it considered necessary radiation exposure or unnecessary radiation exposure? Do you have answer for this one?
It is necessary, doctor.
Necessary, yes, because at that time you get exposed. This is your duty, so you have to get exposed from radiation during your duties. So this is necessary radiation exposure. But if you are going to do fluoroscopic procedure, so you are not wearing your lead apron, so you get too much dose at that day. These doses which you received by your body, this is under radiation, or under necessary or under unnecessary radiation exposure?
Unnecessary.
Unnecessary, because you get exposed to high dose of radiation which is not necessary to have it. So ALARA means you have to stop and you have to reduce any unnecessary radiation exposure. This is the meaning behind ALARA principle. So for anyone, spend less time with radiation exposure. Keep distance away from any radioactive sources. Using lead apron shielding material, or lead containers, or lead searing shield. Why? Because he wants to reduce the unnecessary radiation exposure. So keep that in your mind. ALARA means you have to reduce the unnecessary radiation exposure, not the necessary radiation exposure. My duty is my duty. I have to do it. But for unnecessary radiation exposure, you have to reduce the unnecessary radiation exposure. This is the meaning behind ALARA. Okay, so for anyone working in radiation field, that's why we are advising, as per ICRP, International Convention on Radiation Protection, to spend less time with any radiation source, reduce the exposure time as much as you can, keep distance away, because the inverse square law telling us that the intensity of radiation exposure is inversely proportional with the distance square. Keep using the shielding material, which is highly efficient to protect your body from radiation exposure. As you can see here, this is our CR machine, or fluoroscopic machine, and we have here X-ray tube and our image intensifier, or image or detector. So now if you are at 1 meter, you get exposed to 100 milliroentgen per hour. If you double the distance, you get exposed to 25 milliroentgen per hour. So as per the inverse square law, which is very important for anyone, the distance is a significant factor to reduce the radiation intensity. So I advise everyone to keep distance away from any radiation source. The distance is very significant to reduce the radiation exposure. Here we have a good video presentation about the radiation dose received by the patient body. Our patient here, we are going to put here the radiation detector on the patient's skin, and we are moving the patient away and close to the X-ray tube. Let us see here what is the radiation dose received by the patient's skin. In case the patient is close to the X-ray tube and the patient is away from the X-ray tube. So now we are going to move the patient close to the X-ray tube. As you can see here, the reading on the left side, bottom left, is going to be higher, reach to 750, 800, 852, 895, 937 microgram per second. Our dose range is very high. So now it's around 900 microgram per second. What do you expect if you are moving the patient away from the X-ray tube? So at that time, the patient's skin will be minimum 50% of this value. Please, everyone, try to mute your microphone, please.
Mr. Alex, please mute your volume, your voice. Mr. Alex, please mute it.
Okay, I did it by myself. Okay, now we are going to move the patient away from the X-ray tube. As you can see here, radiation dose or the dose received by the patients can become very low. It's around 400. Okay, so it's very important to consider the distance as a significant factor to protect your body and protect your patient from the radiation hazard. As you can see here, this red area, which has high radiation dose, if you are moving away from the patient, so now you are going to the green area, which has less radiation dose. We are not going today to talk about the patient dose. Maybe we'll talk later about the patient dose, how to reduce the patient dose in more details. But today I'm going to tell you more information about our workers. Also, the positioning of the C-arm itself. In interventional radiology, we are moving the C-arm in AP or lateral position, or to put the X-ray tube down or X-ray tube above the patient. Which position is significant, or which position is important, or which position give you less radiation dose to our worker? If you put the X-ray tube down the table, as you can see, more scattered radiation will be towards our extremities. So at that time, the extremities here are less sensitive to radiation because it is not a developing organs. That's why it's preferable to put the X-ray tube down the table, not over the table. But if you put the X-ray tube over the table, so at that time, more scattered radiation will go to the sensitive organ. So the sensitive organ like eye, like thyroid, like stomach, or this body region will get exposed to higher dose. So it's preferable to put the X-ray tube down the table, not over the table. So as you can see here in this video, we are going to measure the scattered radiation coming out from our patient during the fluoroscopic procedure. So now, if you put the X-ray tube down the table, this is our patient. So we are going to compare the the X-ray tube position down, top, and lateral position as well, to see which position is good for reduction or for dose exposure reduction. Here, if the X-ray tube down, you will get 97 microsievert. So if you are moving the X-ray tube in lateral position and the X-ray detector here is beside the image intensifier or beside our detector, you will get around 390 microsievert per hour. But if you are moving in other direction where the detector is close to the X-ray tube itself, I'm sorry, this is close to the image intensifier. It's a 43. That's why it's preferable to stand beside the image intensifier, not beside the X-ray tube. If you stand beside the X-ray tube, you will get more scattered radiation from the patient because most of radiation back scattered from the patient. So you will get higher dose of radiation exposure. While if you stand beside the image intensifier, so only 1% of radiation dose will be transmitted from the patient body. That's why it's preferable to stand beside the image intensifier. So in lateral position, you will get the lowest dose, but if you are standing at the image intensifier side, but the X-ray tube should be in posterior anterior position, should be down the table as much as you can. It's preferable to reduce the radiation exposure for all the stuff around the patient. So now as a posterior anterior position, so the X-ray tube is down, so the radiation exposure or the dose rate here is 1,500, while here a lateral position, the radiation dose or the dose rate is 4,000. That's why we are preferring to use the posterior anterior position instead of lateral position.
Mr. Emmanuel, please mute your mic, please. Mr. Emmanuel, please mute your mic, please. And Mr. Ishaq also.
Source shielding. Now, if you are using the shield as the shielding material, proper thickness of lead material can be used to protect our body from the radiation exposure. Here, it's commonly used the lead aprons in our diagnostic radiology, and these lead glasses or the thyroid shield with different thickness, 0.25 millimeter or 0.35 millimeter or 0.5 millimeter. So as you can see here, if you want to measure the efficiency of lead apron itself, we are covering the radiation detector with lead apron, so you will get a dose here around 7 microsievert per hour. While not using the lead apron, you will get around a dose around 646.5 microsievert per hour. That means the lead apron will reduce the radiation exposure to our staff during the fluoroscopic procedure by 99%. I have a question for everyone. Do you think that is radiation shielding still necessary during my imaging exam? We should cover the sensitive organ if you are going to scan these patient feet. So at that time, it is necessary to cover the sensitive organ.
Yes, it should be.
No, it is not necessary. As per AAPM, American Association of Physicists in Medicine, and American College of Radiology, no longer support using radiation shields for imaging exam. Why? Because all radiation beam now or all X-ray beam become more collimated. This is the first point. Second point, any scattered radiation will be internally through the patient, not from outside. That's why all scattered radiation, after the radiation incident on the patient body, will interact with the patient internally, and all scattered radiation will come through this way, internal, not from outside. So the lead apron is less effective, but the patient has a psychological problem. If you are not covering the patient with lead apron, the patient will be angry. So I don't recommend to do that. But scientifically, it is not effective to reduce the radiation exposure to the sensitive organs, as per AABM and the American College of Radiology. Lead apron should be screened yearly, should be labeled, and should be hanged properly. Don't try to wash the lead apron like that, so at that time you are going to lose $1,000. Do you have any question for this part? Is it clear for everyone? What do you mean by not using the lead apron in computed tomography? Do you mean not using the lead apron for patient or for workers? What do you mean exactly by that? I see one question here. You mean for patients? As I informed you before, the beam of X-ray is well collimated. So all the scattered radiation will come internally, not from outside. That's why the lead apron and the American College of Radiology and AABM no longer support using the lead apron over the sensitive organ. Before or in the past, the X-ray beam will not wasn't well collimated, so you can find scattered radiation. But today we have X-ray beam which is well collimated. That's why we have a collimation test, which should be done for our machine. And if the X-ray beam exceed the field of view, so at that time you will fail the machine itself. So the beam, 100%, you are sure that the beam is well collimated over the field of view or over the organ of interest. You get it? That's very important. The doctors in interventional radiology, all of them should wear the lead apron. As I informed you before, that the doctors in interventional radiology should wear the lead apron, which reduce the radiation exposure by 99%. Because the lead apron has a certain thickness, which is enough to reduce the scattered radiation coming out from the patient. Any other questions? Okay. I don't want to go more details about the radiation units and the measurements. We can talk about this one later because it's a part of basic science. But I will focus on, because all of you, I think, more familiar with all these units and radiation weighting factor, tissue weighting factors. Actually, it's interesting to refresh your mind by this one. But I want to be more practical with you to talk about the radiation dosimeters and the radiation surveymeters. Actually, in our department or in diagnostic radiology, we have to measure the dose received by our body. That's why we are going to use our TLED. TLED or our badges, it is not protecting you from radiation hazard, but only recording your actual dose. So for everyone come to radiology department should wear the badge, which is under his name and under a certain or specific serial number. So all employers should give for any consultant or for any worker or for any radiation worker this badge, which is very important. And there are different types of badge. If you are working nuclear medicine, you should wear the ring dosimeters, which can be used to give you to give indication or to give you information about your hand dose, and the badge, which can be used in nuclear medicine and fluoroscopic procedure, prefer to use TLD badge or OSL badges. There are different types like Inistadose, which is electronic dosimeters, which is more sensitive than the normal badge, like TLD badge, but it has a certain limit, which is 6 millinewton voltage, cannot be used for radiotherapy. But for badges or for TLD badge can be used in nuclear medicine and fluoroscopic procedure and radiotherapy as well. It's very important for any worker to wear the dosimeters. Here, where should I wear the badges? Above the lead apron or under the lead apron? What do you think? It should be weird under the lead apron or over the lead apron. You have any answer? Normally in your procedure, you are wearing the badges over the lead apron?
Under the lead apron.
Under the lead apron. So now you are getting the actual body dose. You're right, not wrong. But you have to ask your vendors. You have to ask your, for example, we have here Landauer company, which is, this company is estimating the dose based on the over lead apron reading, not under lead apron reading. So you have to ask your vendor. If the vendor estimating the percent of those received to the actual body or to the body from the over lead apron reading, so you have to wear it above the lead apron. But if they are not going to estimate this one, so you have to wear it under the lead apron. So you have to discuss this matter, which is very important with your vendor, because if you are wearing the badges under the lead apron and the vendor making the estimation as it is over the lead apron, so you are underestimating your dose. So you have to be more cautious and you have to ask them about that. If you have a pregnant staff, we should issue another fetal badge, which should be here over the pelvis region, and you should wear your badge over the chest region. For the fetal dose, there are a certain dose limit. We will talk about this one later. But I want to tell you, if you are pregnant and you are working in nuclear medicine department, you should avoid any therapy or any radionuclide therapy procedures. You should keep following time distance shielding. You should ask the radiation safety officer to issue a fetal badge for you. This fetal badge gives you information about your fetus dose, and your dose limit will be based on your regulation and your country. But if we are talking about NRC, okay, it's a 5 millisievert in the whole period of pregnancy. So if your dose exceeds 5 millisievert in the whole period of pregnancy, that means you are exceeding the dose limit for the fetus, which is 0.5 millisievert per month. So for fetus dose and fetal badge should be monitored monthly. Should be monitored monthly, regardless you are working nuclear medicine or fluoroscopy or normal diagnostic radiology. Each radiation worker must collect his or her TLD badge from the designated place before start of his or her duty in the X-ray facility and leave it at the designated place after completion of the duty. So you should avoid to put the TLD badge or the badge in the radiation area. That's very important. And if you are missing it, you have to inform the radiation safety officer immediately about this one. Don't take your badge to your residence or any other institute for use. Never use the badges of another staff. Avoid borrowing badges. Missing or badges, in case the badge is damaged or missing, you have to inform the radiation safety officer right away, and the radiation safety officer has to issue a new badge for you. Actually, for badges, it can be monitored or it can be measured monthly or quarterly based on the workflow. If you are working in nuclear medicine department or fluoroscopic department, so it's preferable to be measured monthly. But if you are working in diagnostic radiology, it's preferable to be measured quarterly. So it's based on the radiation hazard and the workflow. You should decide when should I measure the badge for our workers. For to whom should I issue a badge? For any worker in diagnostic radiology? No. For anyone who has a probability of receiving a dose exceed 10% of the dose limit. So if you have a certain worker has a probability of receiving a dose exceeding 10% of the dose limit, you should issue a TLD badge or a badge for him. We have different survey meters. We have a digital one and we have analog one. As you can see here, pancake or sodium iodide. This one is pancake detector, which is very sensitive to detect the leakage, to detect the contamination, but it doesn't give you any accurate value. Sodium iodide detector, which is using the sodium iodide detector instead of the gas. Here in the pancake, we are going to use the gas. This gas, when interaction happen between the radiation and the gas, ions are produced, which can be detected and can be collected here by our electrodes inside the survey meter and give you a certain reading. That's why the operating voltage for radiation survey meter or the pancake is very high. That's why it's very sensitive to detect any radiation leakage or contamination. While sodium iodide detector here detect radiation coming out from radioactive sources or from anywhere, and this radiation will interact with the sodium iodide detector or the scintillator material to convert the X-ray photon or the radiation to light photon. Then this light photon will be converted to electric signal. This one operating will be operated under a low level of energy or low level of keV, so it can be used to give you more accurate reading. This is our area monitors, which has to be mounted in the to detect the background radiation level inside the rooms containing radioactive material.
Oh, sorry.
I have some important questions for everyone. Can the patient become sterile after undergoing diagnostic X-ray? Do you think that if patient come to your department under CT or X-ray, can patient become sterile? Infertile? Do you think it might happen? Do you think anyone working in diagnostic facility can get sterility from radiation exposure? Yes or no?
Answers in the chat box, doctor.
Sorry, doctor?
They are answering in the chat box. Most of them are saying no.
Okay, one of them say yes. Okay. Okay, so the answer here is no. Why? Because the sterility is a type of deterministic effect of radiation. This deterministic effect of radiation, which is threshold dose dependent. That's mean we have two types of radiation effects. One of them is called deterministic effect. The other one is called stochastic effect. The deterministic effect is, I'm sorry. Here, deterministic effect like hair loss, cataract, skin injury, sterility, It requires threshold. You should exceed the certain threshold to be having. And this threshold is around 1 gray. 1 gray is very high value. It will never received by anyone working in fluoroscopic procedure or anyone working in nuclear medicine or diagnostic radiology. That's why you will not find anyone of radiation worker get hair loss or cataract, skin injury because of the radiation exposure or the radiation work in diagnostic radiology, because it requires a certain threshold to be having. While in stochastic effect, we are talking about cancer, leukemia, hereditary disease, or genetic disease. There is no threshold. Based on the linear non-threshold curve, this one indicates that as per ICRB, there is no threshold. One photon might cause cancer. One photon might cause genetic disease. That's why we are avoiding any unnecessary radiation exposure because of the probability of cancer, which requires 20 years to be happen for anyone. So stochastic effects here can happen by only one photon. That's why you have to avoid any unnecessary radiation exposure. But hair loss, cataract, skin injury, sterility require a certain threshold. So no threshold for stochastic effect, deterministic effect appear above a given threshold. The severity of the effect increase with those, while the stochastic effect, the probability of the effect increase by those. Effects occur here within days of the exposure. Effects may happen years after exposure. Include tissue effects like erythema, include only cancer and genetic mutation. So you have to differentiate between stochastic and deterministic effect. So all people working in diagnostic radiology or nuclear medicine under stochastic effect hazard or stochastic hazard. So you have to be careful about that. As you can see here, this is our DNA. 10,000 to 1 million location in the DNA damage every day, and our cell produce repair enzyme trying to fix all this damage. But if the cell fail to repair the damage, so cell apoptosis might happen, or cell degeneration, or genetic or hereditary disease might happen. The same idea here happen for after radiation exposure. The DNA damage appear, so now the cell trying to fix the error. If there is incomplete repair, so mutation might be there. This mutation induce cancer or hereditary disease. This is happen in stochastic effects of radiation. But if the repair totally failed, so cell death or cell degeneration will be there. This is happen under deterministic effects which happen for patient under fluoroscopic procedure. That's why you have a tissue damage for patient under fluoroscopic procedure if the dose exceed 2 gray or 3 gray, and happen for radiotherapy patients. You will find hair loss. You'll find skin burn for patient on cell death or cell generation because the dose now exceed 1 gray. But if the repair succeed, so no hazard will be there. So you have to differentiate. That's why we are, as a worker in diagnostic radiology, we should avoid any unnecessary radiation exposure to avoid the cancer and genetic disease. The cancer and genetic disease probability increase by increasing the dose. The cell death or the severity of deterministic effect increase by increasing the dose. So if I ask you about the probability of the effect increase by increasing the dose, that means we are talking about stochastic effect. If I ask you about the severity of the effect and the dose, now I'm talking about deterministic effect. Okay, so now I have one more question for you. Can pregnant employee continue to work in X-ray department? Actually, as per IAEA, International Atomic Energy Agency, any pregnant employee should have 3 options. If the worker, if we are sure that the fetus dose will not exceed 1 milligram for the pregnancy period, this is per IAEA, as per IAEA. But for NCRB is 5 milligram. So you have to follow your regulations. but IA using 1 milligram. So if you are sure about that, so she can continue her work without any change, but you have to avoid any therapy patient in case of radionuclide therapy, and or there is radiation risk, or can change the job to do paperwork, for example. So she had three options. She can stay or move to another job where there is less radiation exposure, or she can change her job to another one where there is a paperwork. Now you are pregnant and you get exposed to radiation. Do you think you should terminate your pregnancy? Should pregnancy be terminated after radiation exposure? As per ICRB 84, it's based on the radiation dose. That's why medical physicists should be involved in this one. Should estimate the radiation dose to the fetus. If the dose exceed or less than 100 milligram, so at that time, there is no termination recommended by ICRB. But if the dose exceed 100 milligram to 500 milligram, so at that time, it's based on your circumstances, based on your ethics, beliefs. It's up to you. But if fetal damage will be there. Also, for deterministic effects of radiation happen for baby or the fetus, it's based on the period itself or the pregnancy period. At the beginning, 0 to 2 weeks after conception, so miscarriage might happen. This period is called all or none. So if you are in the first or the second week of pregnancy, if something happened for your fetus, when pregnancy will be terminated, or a portion will be there normally. So no need to be worried about that, because this period is called all or none. All or none. So after 2 weeks of conception, so now we are going to organogenesis. Your organs of the baby organs start growing up, so malformation might be there. After the 8 weeks, so now we are going to grow our central nervous system, so mental retardation might be there. After 15 weeks, so now we are talking about the cancer effect. So based on the period, the effect will be different from one period to another, but the miscarriage might happen at the first trimester from 0 to 2 weeks after conceptions. Okay, so I'm not going through this one for hours. We don't have enough time for that. What if patient underwent abdomen CT before realizing she is pregnant? So now, the patient did CT scan and she realized that she is pregnant. We have to estimate the fetus dose and we have to follow ICRB 84 for the radiation dose, if it exceeds 100 milligram or not exceeding 100 milligram. Sometimes you don't have a facility to do pregnancy test, so you have to follow 10-day rules. 10-day rules means that if from the onset of menstruation period, you can count 10 days. Those 10 days you can do any procedure for the patient, including pelvis region as well, without pregnancy test. And if you are going to do CT scan and CT I'm talking about now 10-day rule. This 10-day rule only from the onset of menstruation. You can do any you 10 days in procedure, whatever 28 days, go to 28 days rules of thumb to avoid or abdomen leakage. You can do that from the onset of menstruation without pregnancy test. we can do scan for extremities for sure. As per IAEA, International Atomic Energy Agency, you can do scan for chest extremities for pregnancy. For sure, we can do that. As I informed you before, after justification, if there is no option, so you can do that for pregnant workers. I'm going to talk about Federal Authority nuclear regularity here as occupational and public dose limits, but it varies from one country to another. So I'm not going to, but it varies from one country to another here as occupational dose limits as per Federal Authority of Nuclear Regularity, United Arab of Emirates. As you can see here for the worker, average 20 millisievert over a period of 5 years. This is the dose limit, okay? So here 100 millisievert over 5 years, 50 millisievert over as a maximum dose for 1 year. For person between 16 and 18 years age, here is the 6 millisievert per year. For length of eye for worker is average 20 millisievert over a period of 5 years, 100 millisievert 5 years, less or equal to 50 millisievert for 1 year. For person between 16 and 18, 1 year, 20 millisievert. Any point of the skin for the worker, 500 millisievert per year. For person between 16 and 18 is 150 millisievert. For extremities or hands, feet, forearms, for workers, 500 millisievert. For person between 16 and 18, 1 year. You have to be cautious about the pregnant worker millisievert during the remainder of the pregnancy period. For the public dose limit is 1 millisievert per year. For length of eye is 15 millisievert. For any point of the skin, 50 millisievert. Here, as you can see, if we are talking about something else, we should call dose constraint. There is a difference between the dose limit and dose constraint. Dose constraint, it's a part of the dose limit. Dose constraint, where this is a value where you should do investigation. Why you get this value? Why your worker hit this dose constraint? So this is a part of the dose limits based on final regulation 24. As you can see here, for any worker in industrial radiography and nuclear medicine and radiotherapy, 6 millisievert per year. For diagnostic radiology, 3 millisievert per year, which is lower than the dose limit. For worker in nuclear medicine and radiotherapy, 0.5 millisievert per month. Diagnostic radiology, 0.3 millisievert per month. For hand or finger dosimeters, 5 millisievert. For female workers in any practice who are pregnant or even breastfeeding, 0.1 millisievert per month. You have to keep your eyes on these parameters or those constraints. At that time, you should do investigation and say, hey, what happened? You have to ask the workers, and you should do investigation with proper answer why this worker hit this value. You should put the proper or X-ray or radioactive material. So the radiation signage here should give you information about what's inside the room itself. If the room contains radioactive material, so you should put a signage containing radioactive material. Also, there is a difference between radiation area and the high radiation area. If the radiation exposure exceeding 1 millisievert inside the room, that means you have to put a label with high radiation area. Okay, because our time is limited, I prefer to continue this presentation in more details in the next session, in another session. So it will be highly beneficial for everyone if we are going in more details about the fluoroscopic procedure and dental department and nuclear medicine as well. I'm ready to hear your questions.
Dr. Islam, I am really grateful for your lecture. If someone wants to ask a question, please raise your hand. Okay, Mr. Ishaq, you can ask.
Hello, good evening, sir. Hello, good
Good
evening,
evening.
sir.
Yes, I can hear.
Yeah,
We can
good
hear you
evening.
well.
Mom issue. Okay, I want to ask a question about the protection from this radiation. Hello,
Yeah, go ahead. What's your question exactly?
we are all surrounded by radiation from our mobile phone and also from our computer and our working place. So, what are the best way
Sorry,
of hello?
which type of modality you are talking about, Mr. Ishaq?
I'm talking about the ionizing radiation.
Okay, which one exactly you mean? I talk in my
I mean,
presentation about different types of modalities like X-ray, fluoroscopic procedures, like dental, like panoramic X-ray. Which one you mean? CT.
I mean X-ray.
Okay, for normal X-ray.
Yeah.
Okay, for normal X-ray, you are in the control room, so away from any radiation exposure. Okay, if you are going to use the portable X-ray, you should wear your lead apron. You should wear your lead glasses if you have. You should wear thyroid shield. That's very important to protect yourself. You should follow time distance shielding. If you are going to hit the patient with exposure and you have to avoid any scatter radiation, you have to be away from the patient as much as you can. Or if you have lead glasses, you should be behind the lead glasses or any barrier or lead barrier to protect yourself from the scattered radiation, because in X-ray modalities we are using low energy X-ray, which is not exceeding 120 kilovolt and fraction of second exposure time. You get the point?
Yes, sir.
So you should follow only the normal rule time distance shielding. Time means you have to reduce the exposure time as much as you can to the patient, but you have to maintain the image quality as well. Okay, as a you are a medical physicist.
Yes, sir. Medical physicist.
Great. So you have to design your protocols based on that. You have to get optimal diagnostic image quality with less radiation dose. So at that time, if you are reducing the patient dose, you are reducing the scattered radiation to the staff. Okay, so you have a lead apron in your department, you have a lead screen or lead glasses or lead barrier.
Yeah, we do have.
Yeah, so you should use it to protect yourself. Also, you have to make sure that the room itself is lead shielded. Okay, so you have to do this properly to make sure there is no leakage radiation goes to the adjacent rooms and the adjacent clinics, and the door itself is lead shielded to make sure there is no leakage of radiation. Okay, I'm not going today to talk more details about that, because it's radiation protection. It is not a simple information. Okay, because some people thinking that radiation protection is a time distance shielding. No, the radiation protection is a big science. If you are talking about radiation protection for each room, for each facility, you have many details should be discussed to be more efficient to do a radiation protection procedure in your department.
Thank you, sir.
You're welcome.
Dr. Islam, we have a second question from Miss Aisha Sajid. She's asked about the infrared radiation. Is it harmful in any way?
I'm not sure if it's harmful or not, but from ionizing radiation, in terms of ionization perspective, it doesn't cause any ionization based on the electromagnetic spectrum. Okay, so I think it can be used only for physiotherapy. Okay, for using heating effect, as per my knowledge and my information. I'm not sure exactly if there is a harmful effect in this in terms of heating effect or not, But from ionization standpoint, okay, infrared cannot cause any ionization for because it has no enough energy to knock out electron from the atom. That's all.
Thank you, Doctor. We have another question from Amin Muhammad. He said that some cases require to put operated organ inserted directly on the C-arm detector, like wrist fractures. If it to be easy to change the position from EB to lateral manually rather than rotating the tube, for example, will be some hazard.
If you are going to change the tube, it's based on your location. If you are going to move the C-arm itself from one position to another, during this movement, there is a radiation exposure or not? This is important. This is important question. If you are getting radiation exposure during the movement and where you are standing, you are close to the patient, you are close to the X-ray tube. If you are close to the X-ray tube, that means you get exposed to high radiation dose. Okay, she get her point.
Any further question for our doctor? I see no hand raising or any further question in the chat. So, Dr. Islam, to finish our lecture, we need from you to put for us the quiz you asked.
I'm going to share it now with you, Doctor. So just give me 1 minute. I'm going to find it on my drive.
Okay. During this time, in the name of our society, I hope for everyone to be to understand our lecture and to be happy with us. What we need is to give you information and share our knowledge with you. We hope you all to find our Facebook and LinkedIn pages. Also, we have WhatsApp and Telegram. I will ask our colleagues from the management system to put it in here, okay, on the chat box. You can join us on it. And for further lectures, it will be announced there in our media groups and media chats. Okay. One more thing, we hope that you will find after the quiz, you will find form of your feedback. Okay, our colleagues will send it to you, and we hope to fill it back. Okay, Mr. Owais Aziz, after Dr. Islam put his quiz, I will tell him about your question. Okay. I want to ask all our audience, please, can you put in the chat box after finishing, where are you from? Just to share with us where is your location.
Okay, I share the quiz link now in the chat box. Okay. So I want all of you, please, to open the chat, to open this link, and you'll find yourself in Google Forms. You can start answering the questions. Okay. So I think we need more sessions about the radiation safety, Dr. Muhammad, so we can organize a complete course about the radiation safety for all our colleagues, and also we can ask our colleagues from different expertise. Okay, so we can ask our expertise from different areas to join us as the speakers in this course. I think in different areas, I think it will be highly beneficial for everyone.
Thank you, Dr. Islam. We will do it with you. Doctor, excuse me, tell our colleagues finish the exam. We have a question. Can you answer it, please?
What is the tips for reducing radiation exposure? As you know, the manufacturer finds a solution to choose the size of the head, S or X, S or M or L. Actually, I'm not sure what you are talking about. You are talking about the cath lab, or what you are talking about exactly? You are talking about the fluoroscopic procedure?
I'm talking everyone. Thank you very much, Mr. Islam, for the presentation. I'm talking about the dental examination.
Which exam? Which exam?
Dental examination.
I'm sorry, I cannot hear you well. You can write it down here in the chat box if you don't mind.
Hello, everyone. Hello, everyone.
Yeah, we are hearing you, but I don't know exactly what do you mean, or what is the facility, or what is the machine you are talking about.
Hello, everyone.
Yeah, dental examination. You mean intraoral? You mean the intraoral?
I'm talking about
I cannot hear you. If you are hearing him, Dr. Muhammad, you can.
I'm trying to understand what he's saying, doctor, but I'm not hearing well. He have maybe some bad connection,
Hello?
so it's cutting.
Do you listen me now?
Yeah, I'm hearing.
Yes.
I'm sorry, I have a problem with connection. Do you listen to me?
Yeah, we are listening to
Yeah.
you.
I'm talking about dental examination.
Yeah, which
Dental
dental
examination.
examination you mean? Intraoral or CBCT or what?
Uh, Panoramic examination, 2D.
Panoramic X-ray.
Panoramic.
Okay, for
Yeah,
patient
yeah.
or for worker?
What is the tips for reducing the
Okay,
radiation
for
exposure for
reducing,
patients and worker for both of
yeah, for worker, you should be in the control room or controlled area, because you are working in the machine itself working automatically. No need to be close to the patient. Okay, so be sure that you are under the control or behind the control room or behind the lead barrier. Okay, this is for you as a worker.
and for patients.
Yeah,
For patients.
for patients, you have to reduce first one. You have to reduce the field of view as much as you can. That's very important. Okay, by reducing the field of view, you are going to reduce the exposed area of the patient. Okay, and you are going to protect the esophagus region and the neck region and the eye region from any radiation hazard. So you have to use the proper field of view for the area of interest. Okay. Sometimes we are letting the patient wear the thyroid shield during the panoramic X-ray, which protecting the thyroid gland and the neck region from radiation hazard. You can do that, but be sure that the lead apron or the thyroid shield not involved in the field of view, because if you are scanning the patient and the lid of the thyroid shield inside the field of view, the machine itself will increase the dose parameters to the patient. because the machine, by automatic exposure control, will detect that there is a something which is high dense, so it will overcome these attenuations by increasing the dose parameters, by increasing the MAS, milliampere second. Okay, you have to reduce the MAS as much as you can based on the patient size, based on the organ. Okay, so if you are reducing the MAS, you have to make something which is called optimization. You know what I mean? Based on the manufacturer itself. As a rule of thumb, increasing MAS or increasing the exposure time, increasing the patient dose. For KV, as a rule of thumb in X-ray imaging, increasing KV, reducing the patient dose. You get the point? But you have an issue with panoramic X-ray. For panoramic X-ray, you need more contrast of the image. So you have to reduce the KV as much as you can. That's important to increase the image contrast. So you have three main parameters: acquisition parameter, exposure time, MAS, KV value. The fourth one is the reconstruction algorithm, which can be used to reduce the noise in the image. So you have to go through the machine itself. If there is an option to use iterative reconstruction algorithm or different filters to smooth the image and reduce or denoising the image, so you can get better image quality with less radiation dose. You get the point?
Yes. Yes.
So you know your machine better than anyone. So you have to reduce the MAS and see what is the image quality, if it's accepted or not. So as you, or since you are reducing the dose to the patient and you still getting or still having an accepted image quality, you can reduce it. Okay? So it's based on different criteria. It's based on the machine, based on the X-ray tube, based on the type of the detector, the image processing techniques you are going to use, different parameters. That's why I advise any medical physicist at the beginning to do a certain trials. Maybe you can use a certain phantom for this one, and try to change the acquisition parameters to get the standard protocol which can be used for your procedures. You know what I mean?
Yes.
And I think this is a good idea because it's specific for each machine. You cannot say use this value, use this value, use this. Even the machine itself come to your department with a certain protocols. These protocols adjusted by the medical application specialist or the company, which is most of the time not accurate. And you are going to change the parameter to get better image quality. So my advice to you, if you have a certain phantom which simulate the jaws of the patient or the panoramic region of the patient, so you can try to reduce the acquisition parameters by fixing others and see what is the effect, what is the image contrast, what is the image noise, to set for yourself a certain protocol or a standard protocol which can be used for clinical purpose. You get the point?
Yes, Mr. Islam.
So I think now all questions are being discussed.
I'm sorry for this question. Are black skinned people more sensitive to radiation than no, of course. Both of them same. There is nothing like that because we are talking about high penetratable radiation with a speed like 38 kilometers per second. Okay, so even we are not talking about the ultraviolet light, or we are talking about X-ray, gamma ray. We are talking about very high penetrating power radiation X-ray. Do you have any more questions?
I think we finish all, Dr. Islam.
Thanks so much for your attention. Hopefully you get satisfied today with my presentation. And if you have any questions, you can contact with me or with our society members or our society management. I'm really happy to be with you today. Thanks so much. Have a good night.